Dr. Fred, you're on.
Okay. Hello, everyone. Good morning. I wanted to spend the morning here, the time available to us, talking about strategies for achieving lifetime wellness for polio survivors. It's a topic that's become close to my heart in the last 8 to 10 years. And I'll tell you about some of the things that we've tried to do as we go along. The first thing is to come up with some common understandings of what do we mean by health and wellness. And I think all of you who have been living with polio residuals know that certainly wellness is not just the absence of illness. It's really, I think, an ongoing process. It's the favorite definition I have, a process to optimize your physical, psychological, and spiritual potential. And there's a lot of different models, and of course a lot of different research that's been done on this topic. The typical clinical models are the absence, signs, and symptoms of illness, as opposed to the presence of it. But the other people have talked about wellness also being your role performance, so that you can do everything in life that you expect to do, as opposed to being totally unable to do it, which would be the other end of illness. An adaptive definition would be more about being flexible to your environment as opposed to being unable to adapt to the changes in the environment. The other definitions I like is from Dr. Roberta Trishman, who was a psychologist who worked in rehab for many years. And she always talked about these aspects, about health being really a function of both the organic and physical aspects of our life, as well as the psychosocial components, and then the environmental component. And it really was an equilibrium or a homeostasis that people come when you're healthy. You have everything in those three realms in balance. But anytime one of them changes, the others have to make an adaptation. And I think I like that model for that reason, because when we do have a physical disability or a new medical problem, there are changes that go on both in how we think about ourselves and what we expect and our emotions, but also there's frequently adaptations in our environment, both the people around us as well as the physical environment. When we develop programs, we tend to go with this more simplistic definition of health and wellness than in talking about body, mind, and spirit. It's a little easier to understand and adapt to. And certainly we all recognize that the body, the mind, and the spirit are very in one area do have effects on the other. Yeah, that one is a more complex one that recognizes that in addition to the physical components of fitness and nutrition, for example, of your physical health, the mind can really be separated to some degree into both the emotional components of your mind as well as the intellectual one. And the social is really part of the environment. Spiritual things have, of course, not really had as much attention in most of scientific medicine. But clearly, they're very important because of how they affect other aspects of health. And questions I'd pose to you then, are health and wellness really the same? And today, in modern healthcare, what people normally do research on is really called quality of life, which isn't exactly the same as wellness, but I think they're terribly related. And then the other question is, of course, how do wellness and disability relate? Most of us would say, of course, you can be quite well in spite of having a chronic disability, even if a lot of people in the general public don't necessarily understand that. And then the other issue is, what are the components or expectations of wellness, and how do they change when we age? Because a healthy 20-year-old is not the same as a healthy 60-year-old. Well, when it comes to the polios, I thought of it this way that was helpful, that there's several categories of change when you're aging while living with polio sequelae. First of all, there are secondary complications of the polio itself. And these include both the initial sequelae, or the early sequelae of the polio, that include, of course,
various degrees of weakness in various parts of the various muscles in the body, but can also include a variety of deformities, for example, that develop early, or respiratory difficulties. But then there's the late sequelae of polio, which can include progression of some of those initial sequelae, like a back knee deformity that develops, or an arthritis in a knee that has a deformity in it as one gets older. But another late effect, of course, is post-polio syndrome itself, which would be the issue of progressive new weakness developing in muscles of the body. Now, if we separate those secondary complications of the polio itself, there are other secondary complications that really relate to living with the polio sequelae or any type of physical disability. And these include things like shoulder pain that's so common when you have to rely on your arms to move yourself around, or using crutches and canes with heavy weight bearing through the upper limbs. Other ones include your postural problems with progression of postural deformities and scoliosis, or pelvic obliquity problems, arthritic issues, etc., which are much worse or probably do develop directly in relation to the polio sequelae themselves. And then the third category are things that are called comorbidities of aging. And these are things that, of course, develop in any population of people as we get older. But among polio survivors and other people with disabilities, there are unique risks for greater development or more impactful consequences when heart disease, diabetes, obesity, cancer do develop. Another category of change is, of course, psychosocial change. And this is everything from the cognitive and emotional aspects of accepting limitations as we get older, either direct from any of the above aspects of secondary physical changes, but they can also include emotional changes like the development of depression. It can include new limitations and how that makes you feel, or how you choose to make physical adaptations to them. And then lastly, I would bring up environmental changes. These include things like your social community, where we all experience losses, from parents to good friends to spouses to even children. Community changes. Certainly our communities are more accessible now than they used to, but we have tragedies in our communities, including floods, and you had Hurricane Sandy not long ago. Those are environmental changes that we have to, again, accommodate. And then there's cultural factors. We're so fortunate in this instance for the cultural changes that bring us technology of computers and webcams, so we could do this kind of thing, cell phones, and what they've done for certain aspects of security and staying in touch. So they make things easier, but they can create other problems. Well, what are some of the expected physiological changes that just occur in everyone with aging? And there's a long list of these in the gerontology research that include things like the number of nerve cells in your brain, with brain atrophy, that is a contributing factor to why people develop more memory problems as they get older, but also a loss of number of motor nerve cells that can lead to some degree of muscle loss. There are declines in your vital capacity, so whenever you do tests, they always compare how much air you can move yourself to how much air a healthy person is expected to move based on their height and their age. Similarly, heart rates, and cardiac output. There's usually a direct line relationship that tends to decline as we become older. Changes in blood pressure can occur with aging and not necessarily directly be an illness. There are changes in our collagen tissue that makes us less flexible, that probably leads to easier inflammation with stress and strain. There are changes in our cartilage that contribute to osteoarthritis. And, of course, there's an interaction with our nutrition on many of these above factors. There's declines in our bone mineral mass. that's very complex, but certainly one aspect seems to be your genetic programming of aging. And then there's changes in carbohydrate metabolism that further contribute to why we get heavier or it's easier to get heavy when we get older. A number of years, this is almost 25 years ago, I guess, or 20 years ago, we did some studies back in Michigan on groups of our Michigan polio survivors, and we did an in-depth analysis on 120 that we thought were representative of the whole group, not necessarily just clinic patients. And when we did the interviews and examinations with them, one of the things we were looking at were medical comorbidities. That is, other medical conditions that we didn't think had anything directly to do with them having polio. Many of them age-related ones. And it turns out that you can see the above list, none of them by themselves was terribly common, but when you added them all up, it was over a third of the people that did have another medical comorbidity that was significant enough to affect their functional capacity. And so that is going to be compounding any effects of their functional capacity from their original polio sequelae, including the development, as you can see on there, of new muscle disorders or nerve disorders like stroke and multiple sclerosis that are very common in the general population. Now, I want to say a little bit about, because I'm going to share some research and experiential learning with you that relates to health and wellness and aging from my years of experience in working with the spinal cord population. That was the other big group of people with disabilities that I've spent a lot of my professional career with. And the interesting thing is that there are probably more similarities than differences between how people age with spinal cord injury as they age with polio. Certainly, for those of you less familiar, these are a few things to keep in mind on that topic. One is that both spinal cord injury and polio, of course, can result in paraplegia or quadriplegia, which are the terms used for significant weakness in the lower limbs or in all four limbs. And, of course, in polio, it can be even interesting combinations of severity of 1 to 4 limbs. And these obviously all relate to physical functioning, particularly mobility functioning and use of the extremities for physical tasks. Now, some of the differences include that the demographics are pretty different. The big polio epidemics, of course, in the U.S. Were so long ago now that our average polio survivor age and of people who developed polio while they were living in the United States is generally now well into the 60s, probably 65 to 68, depending on which group exactly you're talking about. Of course, if we look at it worldwide, we have a lot more polio survivors who are still in their 20s, 30s, and 40s. But in the spinal cord population, we see people of all ages, but the peak age is, of course, between 18 and 35, in the younger years. And the gender differences, of course, in polio were pretty equal between men and women, whereas in spinal cord injury, it usually runs at least 75 to 80% men versus women. The problems of aging, as people have studied them, are more similar than different, particularly among people who are wheelchair users or have to weight bear and walk using major devices so that there's excessive weight bearing on their arms. There are a lot more what we call cohort longitudinal research that's been done in spinal cord injured people, mostly because the research has been done in the last 30 years, and you have populations of them that are all injured over the course of a year, and then you can follow them. They're aging continuously. Whereas in the polio, it's a one large cohort of people who were developed their paralytic polio primarily in the late 40s and the early 50s. And I think there's really a lot of opportunities to learn from each other in those groups, and I'll be sharing some of that information back and forth as we go along. Now, one of them are the psychological factors that since we're talking about health and wellness and quality of life. There's a lot been done on quality of life after spinal cord injury. And this study found that higher quality of life had its highest correlations with people's ability to have a locus of control, a total locus of control that was internal as opposed to external, a sense of coherence or making sense out of life, hope, having a purpose in life, high self-esteem and self-worth, positive affect as opposed to negative and depressive affects, growth and resilience, and acceptance of life as it is, including their own limitations. All of those were correlated highly with high quality of life, whereas low quality of life was correlated with the negative affects. People who are negative are helping create their own problems, no doubt. And a post-traumatic cognition, which I would translate, especially for the polio survivors, is more of a victim mentality, or people that tend to always be preoccupied with poor me and how one more thing has hit me. That attitude is not actually helpful in achieving a high quality of life. This study was fairly complex, and it looked at aging and quality of life. And the notion of aging is both your chronological age as well as how many years you've been living with a disability. Now, if you had a congenital disability, then it would be the same. But for most people, there would be a difference, and especially in the spinal cord population, that years after injury turns out to be an interesting variable. And some of the results they found were expected results that included people who had fewer health and fewer disability problems did have higher quality of life. Older people, in fact, had more health problems. That's not a surprise. And higher levels of injury, that is to say, the more severely physically disabled you were, then you obviously had more disability problems. Some of the other results that they were easier to understand and explain included older ages did seem to have lower quality of life, interestingly. Although it was contrasted with the longer that the people lived post-injury, they had higher quality of life. It's sort of contradictory. So there's two, it's sort of like that factor of how you get used to it, I suppose, and put it into the background for people who are newly traumatically injured from spinal cord injuries. Another one was the perceptions of quicker aging than their peers because they were spinal cord injured, contrasted with recognizing or focusing on that they were aging. Aging was harder on them. It was worse because of how impactful it was on their health and disability. And then they found that the longer people were post-injury, they had less perception of the quicker aging, which turned out to be a negative factor. And so some of that would be, but the other surprising result that I thought was particularly worth sharing with a polio audience was that fatigue was the greatest problem among the younger polio, or the younger spinal cord injury people, and the ones that were more newly injured. And I think this is relevant because in my own experience, the fatigue problems are probably greatest in the younger polio survivors because they're still working. They still have larger expectations for themselves and society, and their families all have larger expectations for energy and activity than people who become and get into their 60s and start fitting into the older age group, the retired age group, where it's easier to adapt to your limitations and energy. The other surprising finding was that the older age people actually did complain of less fatigue, and they had lesser of these perceptions of quicker aging, even though they acknowledged the worse aging. Okay, if we move on then to talking about promoting wellness among aging polio survivors, what are some of the principal characteristics? And I think most of these you'll be familiar with. Certainly we would all agree one is to optimize activity and exercise, and we're going to spend a little time talking further about that. Another principle is, of course, to optimize nutrition and sleep. Another would be to prevent the secondary complications that occur with getting older and are particularly associated with post-polio aging. And those can be addressed either through direct prevention strategies as well as by early recognition and rapid treatment should those complications in fact start developing. A fourth pillar is, of course, patient-family education. We call it, essentially that's what we're doing here. And there's so many resources now that we do have available for wellness problems in the polio survivors, both printed materials from books and pamphlets to video programming to computer programs to formal programs to individualized methods that are more one-on-one of learning. And then lastly, I would also talk about patient empowerment, and that's, of course, particularly important when we're talking to professional audiences that sometimes need reminders that the control has to be back in the hands of the person who has the problem. And peer involvement is so important and key in my experience to promoting that kind of learning. Now, some of the other additional strategies I'd bring up are remembering that comprehensive reevaluation visits every 6 months to 2 or 3 years for polio survivors, it can really be very, very important. And it's just like your general primary care physician. And we need to recognize that the health screening guidelines that apply to our general non-disabled peers still apply to polio survivors who are disabled as they age. Even though how to test them and some of the interpretation can be challenging and different. Another is having a functional needs assessment or review by members of the rehabilitation team, such as physical and occupational therapists, as part of a comprehensive reevaluation. It can also be extremely helpful every few years. Another issue are organized programs, and here I bring up one of the ones that I'll spend a little time later talking about, that includes the development of residential retreats and camp programs where people are spending some time away from their usual living environment in their homes in a health-promoting milieu or environment, and where people can take the time to experience some different activities and strategies and way of being with people that can contribute to their health and wellness, as well as solve problems. Another type of organized program is, of course, like the one you're at today, where we have seminars and conferences. A third one I throw out to you to think about as a strategy to promote wellness is really thinking about specialized supportive residences and services. And this is particularly important as we age, and there's fortunately, again, more and more of those that are going on, at least in our American society. Things like assisted living facilities, senior living centers, communities, special communities that have level of care needs built into them, can really make a difference in promoting wellness as people live. But they do require, of course, changes, and they're not necessarily for everyone. And there's a balance between creating these, what I would call separate environments that sometimes can turn into ghettos, that have age restrictions because they're all older people, or you have to have such and such a service of meals or whatever, versus an integrated type of program where you have universal design. And there are advantages of both for different people. Okay, so what are some of the key content areas then as we talk about developing health and wellness programs? Well, when I've done it, I've started with this notion of body, mind, and spirit, and making sure that we included programming of all three aspects, those three aspects of health. And when it comes down to the nitty-gritty of what can you do, it really boils down to most of them fit into one of these three categories, either exercise or activity, or secondly, nutritional changes, and thirdly, lifestyle, if you will. I'm just going to share this quickly. This is a picture of something I ran across in one of the newspaper, the Sunday supplements of the newspaper, which was a reference to a physician named George Culver, who was appointed as the first physician for the U.S. Congress, the Senators and Representatives, back in 1928. He really was apparently there for almost 25 or 30 years and was really notorious for promoting health and wellness. And I thought his advice was very simplistic, and it's probably what you've heard from your grandmothers, but I thought it was worth just reminding us that none of this is new rocket science. And his tack was what he called the 10 Commandments of Health and the 5% solution. And his 10 Commandments of Health included these, which I thought were very nicely put. One was eating wisely. Secondly, drinking plentifully, of course, of water. Thirdly, eliminate thoroughly. Bathe cleanly. Exercise rationally. Accept inevitables. Don't worry about what you can't change. Play enthusiastically. Relax completely. Sleep sufficiently. And check up occasionally. Not all the time. And his P.S. was, if you would give 5% of your time to keeping well, you won't have to give 100% of your time to recovering from illness. So, here's a study that was done quite a while ago now by an investigator named Walker, health psychologist, I believe. And she recognized these 6 dimensions of health, of healthy lifestyle. One was self-actualization, being able to really carry out in life what is important to you. Secondly, it's health responsibility. Don't blame it on others or expect others to do it for you. Thirdly is this issue of exercise and activity and coming up with the right healthy amount rationally. Sensible nutrition, interpersonal support, and stress management. Okay, so let's start talking about promoting exercise and activity. And I think I spoke on this topic. I think the last time I was in New Jersey. I would say out here in New Jersey, even though I'm not actually out there, just by video today. But certainly we all recognize there's many benefits from promoting exercise and the right amount of activity. Hopefully a high amount of activity as possible. And some of the benefits include, of course, promoting cardiovascular fitness, keeping your cholesterol and lipid profiles optimal. It certainly helps with weight management. Neurologic recovery was important for the spinal cord injury patients, but I think for polios, you could think of it as it also does, that is, a high level of activity and exercise can contribute to slowing down the age-related weakness that tends to come on among polio survivors as they get older. It does contribute to a healthy immune system. Exercise does make sleep usually easier and better, more healthful. It does contribute to better bowel habits. It contributes to self-image and self-efficacy because you can get things done with energy. And it does help with most aspects of pain management. There are a number of resources now available for promoting exercise and activity among people with physical disabilities, including the National Center on Physical Activity and Disability out of the University of Illinois. And there's a lot of wonderful resources there, and they have a great website that I think Gene and some of the other people there have and can easily get you from PHI. Another strategy is, of course, using and finding specialized equipment and programs, such as the water exercise programs, the variety of new bicycles, dance classes and adaptive dancing, yoga class and Tai Chi classes that can be very helpful. And a lot of them are available in more and more communities. And I think it's important that you recognize that there are options both on the community level but also on specialized facilities such as gyms and health centers that are more and more including equipment that is appropriate for people with physical disabilities in wheelchairs or otherwise, as well as the things that you can do at home that make it easy but can be quite expensive and awkward for finding space. Another one, next slide, is Action Canada. It's an interesting group, I think was developed some physical activity guidelines for people with spinal cord injury. We probably should do them for people with polio, but they're not all that different. Go to the next slide, because that's what it generally looks like. It was done with some money from the Rick Hansen Foundation. It's talking about the fitness benefits that come with at least 20 minutes of moderate to vigorous intensity aerobic exercise 2 times a week, as well as strength training exercises 2 times a week, and goes into the detail of how often, how much, how hard, and how to. And they're worth looking at, because, although they do need some adaptations, especially on an individual basis for polio survivors. Now, there are a lot of controversies, as you know, about exercise among post-polios, with some people claiming it's great, it's bad, you shouldn't do it. There's been a lot of fear and misunderstanding that's intermittently developed over the last 25 years about this topic. But in my opinion, it really is not a matter of being good and bad. It's all about the detail of the type and intensity of the exercise. It's about making the best choices on the method of exercise, which muscles are the ones that need to be targeted, and you do need to acknowledge whether the person really clearly has post-polio syndrome or not. Okay, some of the definitions, I think most of you know this. Exercise is usually defined as planned, structured, repetitive bodily movement, as opposed to physical activity, which is movement that occurs during the course of daily activities. And therapeutic exercise is, of course, that planned, structured, repetitive movement that's done for a specific health purpose, like keeping your heart stronger or recovering from something or getting stronger. Common sense facts about exercise, of course, include that inactivity rapidly leads to weakness and deconditioning, and certainly overexertion can lead to injury, pain, and in polio survivors in particular, it can contribute to overuse weakness. We always laugh. You have to have a little humor, but certainly avoiding overexertion can be overdone by people who use it as an excuse to just be lazy and not do much and stay in bed. So is exercise good or bad? Well, as I said before, the devil's in the detail. Just like apple pie can be a wonderful comfort food that we all enjoy, or it can contribute to a really bad healthy waistline and lipid profile. Even our anecdotes such as conserve it or preserve it, which we think is a helpful counterpoint to the use it or lose it mentality that polios lived with in the 40s and 50s. However, it can be also overdone and used as an excuse, okay, to not get involved. So, type and intensity of exercise is where it's all about, and I think most of you know there are at least 3 major types of therapeutic exercise. We talk about one are flexibility exercises, strengthening exercises, and then conditioning and endurance exercises. Flexibility exercises involve maintaining the optimal length of our muscles, so they're not too short and tight, or they're not too loose and unstable. And so the flexibility exercises take muscles to the point of tightness and hold, unless it's an overstretched and elongated weak muscle. Flexibility exercises are important for pain management as well as for healthy joints. Strengthening exercises can be done in a variety of ways. The typical types are your isotonic exercises, where you're lifting a weight with your hand and moving, so there's movement involved with resistance production by the muscle, versus an isometric one where you're just lifting and holding it there, okay? So you're not moving it, but you have to maintain a consistent, strong muscle contraction. Or an isokinetic one, which are done with machines that allow you to maintain the same amount of resistance throughout a variable degree of motion, since the lever arms change the actual forces. Other part of strengthening exercises that's important is that they're done either concentrically or eccentrically. Concentrically means the muscle is shortening as it's lifting the activity, like a typical biceps curl, whereas the eccentric muscle contraction is as the muscle's lengthening, as you're putting it down, so to speak. And eccentric contractions are the most dangerous from the standpoint of tearing muscle and contributing to injury. So some of the key principles then of strengthening exercises, especially for polio survivors, are to use low repetitions. Usually we're talking about 3, 5, 8 to start with, but relatively high resistance. And by high resistance is something in the area of 50 to 60% of the maximum resistance that a person could do once. You don't want to start there even at a 5 to 8 area on a regular basis. But it's a general rule of thumb to something in the 50-60%, if possible, for 3 repetitions maximum. And then advance very slowly, maybe only 1 or 2 repetitions every few days. And we always like to quote Dr. Jacqueline Perry, who some of you may know actually did pass away this past year, well into her 80s. Had a long, wonderful, productive life, very important to our polio survivors in the U.S. But she always said if there was pain or fatigue, then reduce that amount of resistance by half. This slide was, it's just a reminder of normal fatigue thresholds, where if you take a normal activity, such as walking, where each step normally is only taking something like 20% of the normal maximum strength in the key leg muscles for walking, you can usually walk pretty much forever. You get tired eventually, obviously, but young infantry troops can walk all day. On the other hand, once you start involving an activity that takes something like even 37% of the maximum strength, you're going to tire much more quickly, and optimally to prevent for that activity to continue a long period of time, you need to balance 50% rest, 50% of the time you should be resting versus 50% of the time actually doing the activity. Then you could go on forever. Whereas if it's 70% maximum, then you have to rest 90% of the time and only have 10% involved in the activity to prevent fatigue. The reason that's important for polio survivors is many polio survivors lost a significant amount of nerve cells, and their maximum strength is in fact reduced, even if they still have enough functional strength to do normal activities such as walking. But for them to walk, they're needing something like 37% or 50% of the maximum strength of their leg muscles. Therefore, they do tire much more quickly as they're walking or carrying out what other people would consider normal activities. So when you talk about fatigue, that's always an important issue to think about. Now, when we talk about what muscles to target among polio survivors, there is a 5-point classification system Dr. Halstead developed some years ago. I think most of you have probably heard this. And it's important, particularly if you identify a therapeutic goal for an individual muscle. Then studying this is often beneficial. And it puts the polio muscles into those that probably did not have any clinical involvement with polio versus those that, in fact, lost nerve cells, but they're not getting weaker, apparently not getting weaker, and their EMG appearance looks normal other than there are a reduced number of nerve cells. A third group are those muscles that are, again, not getting worse clinically. There's no symptoms, but the EMG suggests that there is some muscle membrane instability, like there's constant muscle fiber, nerve twig loss with remodeling and regrowth coming to equality, but they usually are chronically weak muscles. And then there's the fourth group, which are the ones that are clinically unstable, where the muscle is getting weaker in spite of it's being used. And the EMG does show, again, a picture of instability. And then there's lastly the severely atrophic muscles in which there probably isn't enough function to get weaker. Now, the methods of exercise that can be used for strengthening are quite varied, and some of the more common ones include free weights, your TheraBand, which is that stretchy plastic that the physical therapists like to give people, easy to use in your home, stick in your suitcase if you're going to travel. There's all kinds of complex machines. There are exercises involving you moving a part of your body. down on the floor or a table. And then there's targeted movements of your body independent of moving a great deal of weight. Now, the conditioning exercise, if we move on from strength into conditioning exercises, then the key is, of course, for increased endurance. And you can either do that for the whole body, increased endurance, in which the important thing is to aim at your target heart rate versus endurance of specific muscles when you're going to focus on more repetitions. Now you want to do 20, 30, 40 repetitions, maybe with breaks in between, of course, but you need lots of repetitions, and therefore you will use it at a lower resistance. That will increase your endurance and lead to less fatigability when using that muscle. When you're targeting heart rate, you want to lower the percent target heart rate the longer the exercise needs to go on. And certainly if people have heart disease, then they need to have monitoring done, particularly as they begin any type of a program that's going to target heart rate and try to build cardiovascular endurance. We found that interval training is, of course, the key for polio survivors in conditioning exercise. Because the muscles themselves tend to fatigue rapidly, you can't keep doing it for as long. They do fatigue more rapidly, so you need lots of rest breaks. But as long as the rest breaks are relatively short, like a 1 to 1.5 minute rest break, then if the activity resumes again, you still get the conditioning benefit for the heart or developing it for that particular muscle. Just a picture, one of my favorite polio survivors, Marvin Ostie, that started the Upper Michigan Polio Survivor Support Group back in the 80s. And in his last few years of life before he died, he had pretty severe heart disease, complicated by his breathing and his polio. And we really worked with him, and he was a trooper of trying to, get on the treadmill with supports and coaching from an expert physical therapist who understood polios, and he gave it his best, and we kept him going as long as we could. Methods of exercise to build endurance include walking, the mainstay, including walking indoors on a treadmill where it's safe and you've got something to hang on to. Stationary bikes are great, and there's so many different varieties of those. Rowing machines, we love the New Step machine, which allows you to sit in a comfortable position with back support and use both arms and legs reciprocally, and if there are some limbs weaker than the others, they go along with the inertia of it. There's an elliptical, which can't be used by a lot of polio survivors in my experience. Arm ergometers are great for the people who have relatively good arms, but not enough strength in the legs to use for endurance training. Free weights, body weight. 3 to 4 training bouts a week is what's usually necessary to reach goals for endurance training, but only 2 or 3 are sufficient then to maintain most of the gains that have been made. Now, a couple reminders of exercise and post-polio syndrome, reminding us all there is no universally accepted definition of post-polio syndrome. It is a diagnosis of exclusions and fairly complex, but I believe that the exercise approach is really the same. It's just that your level of being careful, I guess, of being careful to monitor for overuse and complications needs to be high. So you need to be on the alert. And generally, if we know we're trying to get a person with post-polio syndrome stronger, we're going to start at the lower percent of their maximum force as we begin, as a precaution. Activity and exercise habits before any new weakness is noted must be honestly described. I bring that up as an issue of post-polio syndrome being that you're getting weaker in spite of remaining active. In truth, many people become less active and don't really like to recognize it because you don't see yourself and you don't monitor it very closely. And so I think the next slide actually shows that. Some of those factors include an unawareness of strength loss from the acute polio. In other words, it was involved, but you tended to minimize it because another part of the body was so much weaker. Then there's the aging process itself that contributes to greater weakness. Gaining weight makes it seem like you're weaker because you're moving more all the time and fatiguing more rapidly. poor nutritional habits regards your energy sources, which can contribute to fatigue and loss of muscle. Not enough protein because people worry too much about their fat. Underactivity and deconditioning, as we said. Overactivity and overuse can contribute to greater strength, and you're just exhausted. People are trying to do too much with poor pacing skills. So all of those can lead to perceptions of loss of strength that can be reversed, okay, and are probably not true post-polio syndrome. Well, a few years back, Post-Polio and Health International did create a task force with a lot of health professionals and therapists and consumer input, and developed these recommendations on exercise. First of all, that an individualized exercise program can enhance health and functional activity tolerance of polio survivors. It can be safe. Professionals with knowledge of post-polio syndrome and post-polio late effects, as well as of exercise, should define and supervise the individual exercise programs for optimal safety and effectiveness. A 2-month minimum is usually needed before a transition to an entirely self-directed program. More and more we're using coaches and exercise trainers that are more available to the general population than they used to be. We follow the general principles of low to moderate intensity with slow progression and pacing, and remind people to consider rotations of exercise types with less frequent bouts and longer duration of times to achieve goals. So pain and exercise, a couple reminders: muscle pain versus joint pain. Muscle pain is what's unique to polio survivors. Joint pain is more complex, but you're more subject to joint pain if you have weak muscles stabilizing and supporting joints. Muscle pain can occur with daily activities. If it occurs with daily activities, may require some modestly painful strengthening exercises to resolve, and particularly to avoid getting trapped into the vicious cycle of when pain develops, we rest, but then we get weaker from disuse, and then we get pain more easily again when we try to do the activity that began the process. And lastly, I would just mention that this fear-avoidant attitude toward pain and activity is a problem throughout the whole U.S. population, and why we're having people from Michelle Obama to many others who are promoting exercise and to help with the problems of obesity. Acute and chronic stress and strain syndromes, that's a mouthful, can occur in many parts of the body, but we're particularly worried about muscles and then the tendons and the insertions of the muscle onto the the bones around the joints. Also, ligaments, which are not really directly related to muscle, but are a part of the joint itself, that stabilizes the joint and limits its movement. And they can become inflamed very easily also. Then we have disc problems in the back and the spine, as well as the joints of the spine. And then we have peripheral nerve problems that can get compressed and squeezed, such as carpal tunnel syndrome or problems in the foot and ankle. And then we have whole body stress disorders that are really chronic stress and strain syndrome, probably fibromyalgia. Well, I always remind people that there's nothing ventured, there's nothing gained when it comes to trying an exercise program. If you do it with your eyes open, with good advice, then there should be no significant risk, because what's the worst that can happen? If something starts developing, you stop and you got to modify it. And if you can't find an acceptable solution, then it may, in fact, not work for you. But smart use of adaptive equipment is terribly key, and learning from others helps a great deal. So the conclusions on the exercise studies that have been done by a variety of researchers are that some muscles can certainly improve. Polio muscles can improve strength, and many others can improve endurance. Some post-polios can improve their general cardiovascular fitness. Interval training and pacing are essential to that success, and goals of the exercise should be clear to everyone involved. Okay, moving on to some of the other aspects besides exercise and activity. There's the big topic of nutrition, and unfortunately it doesn't get nearly the degree of research from the medical establishment that I think it really deserves. Some of the obvious ones are, of course, to monitor body weight. It's so easy to put on weight and not be aware of it, and also monitoring body weight helps you if there's something that happens to your heart or metabolism that would lead to fluid retention, because that's a rapid way of gaining weight that doesn't have much to do with your eating. Certainly your lipids is another issue to potentially monitor, and particularly for men who have significant mobility disability from polio, the lipid profiles are almost always suboptimal. Blood sugar and monitoring for type 2 diabetes, big issue as we get heavier and older. Fluids and fiber for colonic health is another important thing to remember. Swallowing difficulties are common in the aging polio population and need to be, again, on the alert for and addressed if they do start occurring, choking in particular. GERD symptoms can be actually mimicked by sleep apnea. And then through the night, the vocal cords get irritated, and then you have trouble swallowing and choke on your food. Body composition and quantity, food composition and quantity has to do with eating the right things, nutritionally dense food that has lots of good vitamins and minerals and fibers with relatively few sugars and the wrong kind of fats. Medication effects, of course, can influence nutrition. Often they interfere with the absorption of many vitamins and minerals. And so it's not a simple equation of what goes in the mouth and then what actually gets into the bloodstream and can be used by the liver and then ultimately circulated through the body. And it's why when we talk about vitamin and mineral intakes, we also have to talk about the vitamin and mineral levels that can now be measured relatively easily, particularly vitamin D and vitamin B12 and folic acid, which are the ones that can lead to early peripheral neuropathy. And peripheral neuropathy, even of a minor degree in polio survivors, can be quite impactful and disastrous in my experience, because then rapid weakness really sets in quickly. And people want to blame it on post-polio syndrome, but in fact, it's probably being triggered by early peripheral neuropathy from mineral deficiencies, especially B12. Alcohol and substance abuse, of course, are other things that affect nutrition, both especially calorie and healthy vitamin and mineral intake. Now, when it comes to polio and aging and obesity, this gets to be, again, a very complex topic, but certainly you have to be reminded that the heavier you get, the more it does compromise mobility in everyone, and it's easier to lead to overuse of your muscles. So it's a constant, lifelong problem that has to be attended to, and it's common in everyone as they get older, and it relates to metabolism changes and activity pattern changes, not just trying to spend more time eating. And it does predispose people to both type 2 diabetes and arthritis. This one actually shows some research from spinal cord injury again, where people have measured the risk of developing type 2 diabetes is clearly increased. And it probably has to do with the fact that they can't exercise as much. Or they don't take the time and effort to learn how to exercise in the different ways that they're limited to. The same is true with their lipid profiles. Tend to be poor, particularly many more of them have very low heavy density or good cholesterol, because exercise does directly relate to in most instances, to the amount of heavy or high-density cholesterol. And a number of studies have actually shown that if you take people with spinal cord injuries and they do get involved in exercise programs, they can raise their HDL levels. Now, when it comes to another aspect, system of the body, the GI system, I think in aging and polios, the important things are, again, your bowel evacuation programs, because the colonic transit times slow down, both with aging and with relative inactivity and lots of sitting. Rectal bleeding and hemorrhoids are common in the older population and probably are more common when you're a sitter with poor activity. It is important to have regular colonoscopies for cancer screening. They're a hassle for anyone and a little more of a hassle they're in a wheelchair, but they can be done safely now with spending some time talking with people who do them and are not necessarily painful, but they may take a day or two out of your life to have the test done. It is worthwhile. The most preventable cause of thing that can be done to prevent cancers, probably. This next one on the slide is the decreased stomach acid predisposing to the vitamin B12 deficiencies. We don't make intrinsic factor that allows us to absorb vitamin B12, even though we may be eating enough of it. And medications commonly interfere, particularly the ones used for GERD and stomach reflux. And then I mentioned the swallowing and esophageal problems that are part of the GI system. Then we could talk about neurological problems with aging. These include post-polio syndrome, which is the new and greater weakness that can occur in up to a half of polio survivors. It can present as long as 60 years after the original polio, and certainly the degree of it and the exact presenting symptoms, how much fatigue versus how much weakness, varies quite a bit. The progression is quite unpredictable. Sometimes it's relatively modest. It can be in steps, or it can seem to be slowly relentless. Treatment strategies can help slow down the progression, and certainly treatment strategies can help people maintain function and therefore quality of life, particularly if they do it with the right mental frame of mind. Polio aging and carpal tunnel syndrome, just a few thoughts on that. It is extremely common. It can be asymptomatic, in which case you can start getting your thumb weaker and your hand weaker, even though there isn't a lot of pain and pain and tingling and numbness that you recognize. It is more common in people who are wheelchair pushers, crutch and cane users, and people who have to use their hands all the time. If surgery is mentioned or being contemplated, definitely have electrodiagnostic studies done by an expert who knows this problem. And certainly using night splints and a variety of stretching and injections are well worth trying before surgery. Even though it is a fairly safe and quite effective surgery, complications can happen, as with anything. Polio, other musculoskeletal problems include osteoporosis. When people get bone scan studies done, they will all inevitably show osteopenia, if not true osteoporosis, in the bones that are in a limb that has always been extremely weak, particularly in people who never walked or walked only with major bracing on a limb. And that isn't something that's getting worse with aging. And in my opinion, probably doesn't need to be treated. The important part is to look at how the vertebrae are doing in particular, because that's what can change and really have dramatic effects on your lifestyle if you start getting vertebral compression fractures from osteoporosis. The appropriate goal is to minimize osteopenia with sufficient vitamin D and calcium intakes. And again, you can measure your vitamin D level and make sure that your calcium intake is high, because we don't absorb it very good as we get older, and we need more of it. Extremity fracture rates are high, both because osteoporosis and osteopenia are common in the polio survivor population, but also because they fall a lot from their mobility disabilities. So fall prevention is certainly something you can do something about, and it's probably even more important than just the metabolic aspect of trying to minimize osteoporosis. Other common problems include shoulder pain, as we mentioned before, particularly in those with lower limb weakness and wheelchair users. And then there's hand pain from arthritic changes in the hand, particularly at the base of the thumb, in addition to carpal tunnel syndrome. And then there's a whole variety of other common musculoskeletal pain problems in the hips, the knees, and the back, and the upper extremity joints. Another reminder is the immune system, which, again, does tend to decline as we get older. And there's not been any good longitudinal research data on that issue with the aging polio survivors or aging spinal cord people. But we do know that the immune system is depressed by chronic stress, by depression, by losses of social support and isolation, by chronic pain, and it's depressed by polypharmacy and just taking too many medications. And the reason that's important, and I think in particular for polio survivors, is because a lot of the research does suggest that there's an immunological component to why some polio survivors more than others do develop PPS. And if it is related to the immune system, then addressing all of these issues of stress and depression and attitude and addressing pain are extremely important so that PPS doesn't develop or doesn't worsen. Breathing issues, just a couple words on that. That's, of course, a whole lecture to itself, but again, age-related declines occur. And it's not only in your chest, in your lung tissue, but also in your chest wall and in weakness of the diaphragm that can contribute to worsening respiratory impairments and putting people over the edge where they do need respiratory support. Yearly monitoring of vital capacity is again, just should be done in everyone who has a history of bulbar polio or has any concerns that they did have involvement of their breathing muscle. And there's many options now for part-time ventilator support. For the sleep apneas where we need CPAP as opposed to nocturnal hypoventilation where you need BiPAP to actually help increase the volume of air exchange. And again, many polio survivors have both, an obstructive sleep apnea in addition to nocturnal hypoventilation. And again, then BiPAPs are what they need. And once you're using BiPAP and doing well, remember that it can again change. In a year or two, you may need to have the test done again because you may need adjustments in the settings on the CPAP and BiPAP that are not so easy to just come up with on your own without testing. The aging and pain was just to remember that anxiety, depression, and activity interference due to pain are related in a number of studies, this one done by Perry, to pain catastrophizing, self-efficacy, and self-acceptance. We referred to some of that earlier. I may skip that one just because we have, in the name of time. It's again some issues of predictors of who gets pain and how important the issue of the psycho-emotional aspects of dealing with pain are compared to what the actual physical pain triggers are. Okay, I want to save the last few minutes here for some talk on holistic wellness programs. There has been some research on them in people with spinal cord injury, things like 6 4-hour workshops with coaching sessions and follow-up calls that focus on lifestyle, physical activity, nutrition, and preventing secondary conditions. One that was done at U of M, Sonny Roller helped participate in that. I advised them. They actually got 20 people in 2 groups, one that did them and one that did not. And they did find that they had some positive results in terms of changing people's health behaviors for the better, improving their self-efficacy regarding health, improving their nutritional awareness at least. Stress management was improved, physical activity became greater, and there were fewer secondary conditions. However, there were no parameters that you could objectively measure that could be changed, probably because it was too short. These are things that are going to involve people's lifestyle and need to be followed over a long period of time. And it's unfortunate that it's so so expensive and time-consuming to do studies like that because the absence of firm research is used by government and insurance providers to not want to pay for things like this because they say they're not proven to be effective. So we have to rely on our own common sense and take it in our own hands. Another study that was done by Alexis Stauffenberg down in Texas. She's done a lot of research on polios as well, and is the one funded recently by PHI regarding vibration. But this one was done on women with multiple sclerosis, and again was 8 sessions of an hour and a half over 8 weeks with some phone call coaching and follow-up. And again, they were able to show on their outcomes that self-efficacy for health behaviors could be improved, health-promoting behaviors were improved, people's mental health scores and bodily pain scores improved modestly. Another resource can be the Living a Healthy Life with Chronic Conditions. These are a series of self-management programs developed by Stanford University, have been promoted and are available a lot of places around the country. You could Google them and look up what's available. There are a number of polio survivors, including Joan Headley from PHI, who went to those about 5 years ago or more and became an instructor. Again, it never has played out fully. I guess it's hard to get enough polio survivors together at the same time and place to carry it out, but they have some wonderful ways of encouraging self-management techniques in people who have chronic conditions. A couple pictures on a program Sonny and I did at the last PHI conference down in Warm Springs, Georgia in 2009. Some of you were probably there. This was a 4-day retreat right before, held at Camp Dream, which is a small part of the Roosevelt Warm Springs campus, where people can go and have residential programs, many of them sports programs. We modeled this on a program that we had done up in northern Michigan. This was our team done in Georgia, and included Dr. Bill DeMaio and his nurse from Pennsylvania, Barb Duryea, who have done a lot of work on health and wellness. Sonny Roller's there in the scooter. On the right is a physical therapist from Upper Michigan who also acted as our coordinator. She's the program coordinator up here at the children's camp. Myself and my wife, and Sue Jones, who is a nurse from Polio Canada in March of Dimes, Canada. That's the campus where Camp Dream took place. Had some nice living facilities, a beautiful outdoor environment, and a nice big hall for meals and for our programs. We had some program ratings at the end of it, and again, people really felt that it was very worthwhile, rated it in the great to almost wow on a group basis for the polio survivors anyway, on education, the right amount of exercise and rest, and what they learned, and how much fun it was. And the cost was quite reasonable.
Yeah, Dr. Maynard, the question is, with muscle weakness, what is the proper balance between exercise and the muscle the weakness that you're trying to negate? Because I have found that over time, with the muscle weakness occurring in my shoulders and so forth, but with the more exercise I do, the more pain I get. It doesn't go the way you were saying that you try to overcome the pain by conditioning. That doesn't seem to be working.
Yeah, I would answer that by saying, it is and there's not an easy answer in a generic way. But I would, a couple thoughts, though, that I would have you think about, okay? And you want to get a coach, a physical therapist, or someone who can see how you're trying to do the exercises and observe you, because you can't see yourself actually doing it. But the one thing you can focus on is when you do get pain, is it clearly a pain in one of the joint structures, or is it a pain in the muscle belly itself, the soft tissue of the muscle? Because if it's in the joint, most of the time it's coming in from a joint structure, then the challenge becomes how to design an exercise activity that strengthens the muscle without straining the joint structures that are causing the pain. And that's a challenge, but it has to be solved on an individual basis. Do you follow me?
Thank you. We have a question here from Gail. Hold on, please.
Just a basic question. What resource is the best that you have found that one can share with a new physician, internist, general practitioner, to acquaint them quickly on the issues of post-polio syndrome?
That's a good one. One of the resources, of course, that's my own bias, but our original handbook on the way it affects the polio was developed, if you look at the title, as for polio survivors and healthcare professionals. And it was meant because you could quickly either look at a topic that was summarized quite succinctly of a general nature, or you could zero in on some aspect, like the breathing problem or the pain problem or the shoulder or the whatever it was. So it is a nice resource to put in the hands of one of the doctors. The other, and it does have references in it, because some doctors don't want to believe anything, or they don't take much they don't put a lot of credence into a resource unless it's published in a medical journal. But those are referred to on the back, and they're easy to look up. Those are my best advice. There's a couple articles, like Dr. Halstead's one, I think, in Science, was a very generic but relatively easy to read, relatively short article if they're interested in, and will spend the time on reading. It's still going to take you 20 minutes to read it, 15, 20 minutes. If they're willing to do that, it's another good resource. They generally aren't going to read a whole book.
Dr. Maynard, we have another question from William.
Doctor, I'm taking up to 11 hours of serious aquatic exercises. Is that too much?
How many hours?
11 hours a week.
11 hours a week. Okay. That's not too much. You enjoy the water environment, your skin doesn't dry out. I suspect that part of that 11 hours, you're not really vigorously in the whole 11 hours. Some of it you're, in fact, bound and or stretching and doing some other stuff. 11 hours of a continuous at a heavy rate would be a lot. But there's nothing wrong with it. If you can do 11 hours of your life in the water a week, I bet you can get some great exercise that keeps you flexible and out and relatively good shape.
All right, thank you.
Does anyone have any other questions for Dr. Maynard before we close? Hold on, please. Allie over here.
Thank you. My question is, how does one exercise adequately without exacerbating bulbar polio's effect on breathing?
Okay, I'm not sure I understand. What did you mean by exercise?
What do I mean by exercise? Well, any exercise you do increases your breathing rate.
The breathing, yeah, okay.
And I've had weakness in my breathing muscles, so I'm very afraid to start exercising. But my doctor says it's a good idea to exercise.
Okay. All right, if breathing is the limiting factor, okay, for exercise, because you start breathing fast and then you feel like you don't get enough air, I would say you may need to consider both the position you're exercising in, because some people with breathing muscle involvement exercise more effectively. They can breathe easier and more deeply, more effectively in a sitting position versus a standing position. Okay, so that's one issue to potentially look at. The other issue is there are some people who, frankly, need to exercise with oxygen supplementation. They don't need oxygen on a regular basis, but when they exercise, they need more oxygen than their breathing muscles can deliver. And so to get started and build the strength of the muscle and to facilitate their enzyme production for utilizing oxygen, they have to begin exercising under supervision while oxygen is actually running. And then that allows them to be able to do it and tolerate it. So those are some of the options that you have to, it's like getting creative. Once you do a thorough individual assessment of the person's breathing problems and establish what the goals are. Why do you want to, what are you trying to get out of exercising? Is it primarily endurance, or is it some targeted muscle areas of strength?
I see. Thank you very much. It was a great lecture.
Thank you.
Thank you, Dr. Maynard. We'll take our last question here for the afternoon. Thank you.
Doctor, my major muscle problem is in the external and internal oblique muscles. And that came back strong to me about a year and a half ago. I contracted polio in 1954 when I was 21. How common is the abdominal muscles in weakness of polio patients?
In my experience, it's quite common. It's frequently not recognized, okay? But in fact, if you studied it specifically, it's quite common. Ask how many polio survivors who were in relatively good condition and thought they had really modest. How many of them do or ever did a lot of sit-ups? There's not very many of them, okay? Because they did have involvement, even if it wasn't dramatic involvement.
Well, it's become dramatic. You just can't function very well without those abdominal muscles.
No, I know. They're
walking, standing, moving, anything. And I was just curious. I didn't know of any at that level, and I was just curious to know how common it might be.
It's actually quite common. I've seen some of them. That was a major problem. It predisposes to back particular, you see, because abdominal muscle strength is very important to a healthy. The other advice I would give you is, if they're getting weak in your later life, exercise is fine, but they're unlikely to be effective in solving a problem. The best strategy is to make friends with a comfortable fitting binder corset, and use that whenever you're going to be on your feet for a long period of time, or you're trying to do a long bout of exercise. It will be the substance abdominal muscles.
I have a belt that you see carpenters and construction people. It that does help. But are you saying there are some that are more beneficial?
Well, I wouldn't say there's no. I think they all do this as long as they're binding adequately and comfortably through the abdomen.
Thank you very much, Doctor.
Thank you so much, Dr. Maynard, and I will speak to you later on this evening, okay?
Yeah, okay, Lee. For setting all this up, and
oh, that's okay. I'm glad it all worked out well.
I think it all worked out pretty well.